So with that, let's get right into it. Our first speaker is going to be Dr. Virginia Weaver. She's an associate professor at the Johns Hopkins University, Bloomberg School of Public Health, with a joint appointment in the School of Medicine. She received her medical degree from New York University and her master's in public health from Johns Hopkins. She is dual boarded in internal medicine and preventive occupational medicine. She has been on the faculty at Johns Hopkins since completing her occupational medical residency and postdoctoral research fellowship there in 1993. She's directed the occupational environmental medical residency at Johns Hopkins from 2006 until 2014. Dr. Weaver focuses on firefighter cancer and workers' compensation issues in her public health practices. She has given numerous national and international presentations on cancer and firefighters and is the author on more than 80 peer-reviewed articles, chapters, and abstracts. She's been a member of the IFF Medical Advisory Board since 1995, and she has served as the medical preceptor for the Residence Physicians Program at the IFF for more than a decade. Please join me in welcoming Dr. Virginia Weaver.
Good morning, and thank you so much for that kind welcome. I would like to thank the General President. I would like to thank Pat Morrison and Jim Brinkley for the kind invitation to be here today to talk about a topic that is so important. So I'm going to focus for the next 45 minutes on the research that connects cancer risk in firefighters. I'm going to discuss with you one of the standard studies that we used for many years, the LeMaster study, and then I'm going to discuss some of the more recent studies that have come out in the last couple of years, because this area has become very important and a very relevant topic, particularly recently. So we'll talk about what the research shows us. I'm then going to focus on what we can do. What should be the response? Because it's not enough just to know that there's an increased risk, but then we want to determine what proactive steps can be taken in response. So we'll talk about cancer screening, and we'll talk about primary prevention from a non-occupational perspective. My colleague Larry Petrick will talk about the occupational primary prevention approaches. And then finally, I'll finish up with just a couple slides on the medical basis for why presumptive legislation for cancer is so relevant and so important. So let's start by talking about the types of research that can be done to determine if, in fact, the exposures that you all have in your day-to-day jobs increase risk for cancer. Now, my co-panelists, Larry Petrick and Amy Howard, are going to talk in more detail about the components of smoke and diesel exhaust and flame retardants, which really set the stage for why we would even do research to look for an increased risk for cancer in the first place. Based on that exposure information, it's clear that such research does need to be done. So how do we go about doing it? Well, first, we need to keep in mind that cancer is extraordinarily common. It's the second leading cause of death in the United States after heart disease. So that means that if you personally are not a cancer survivor, you will clearly have known someone who is. It's just that common. The next important thing we need to keep in mind is that there are many, many risk factors that have been identified that increase the chances that someone will develop cancer. So we all know about smoking. Many of us know about diet, genetics, family history, and then a range of work and non-work or environmental exposures. So those need to be considered as we look at risk. And a final challenge is that cancer takes years to develop. So in contrast to when you have an injury in the midst of fighting a fire and it's very clear that that injury is work-related, it is much, much trickier for cancer, which is going to develop years after the start of the exposure. That's called latency. So what kind of research can we use to sort this out? We can use animal studies. You can expose rats or mice to chemicals that are commonly found in smoke or in diesel exhaust, and you can see if those animals that are exposed have an increased risk for cancer compared to animals that are not exposed. That's a bit tricky because animals are not humans. So when possible, we like to look at human studies. Now, obviously, you can't take a group of humans and say, you're going to go become a firefighter, or you're going to be exposed to benzene or whatever, and you're not. So we're left with a technique called epidemiology, which tries as much as possible to compare those who are exposed with those who are not exposed, while taking into account other differences in the population. So for example, firefighters can be studied, and their rates of different types of cancer can be examined based on death certificates or cancer registries. All right? And you compare those rates with members of the general public who have never served as firefighters, or with groups of firefighters whose exposures are thought to be lower. Another type of study in humans that can be conducted is called a case control, where you look at populations who have a certain type of cancer and you go back and ask them, what did you do for a living? What kind of exposures do you have? And you see if those exposures are similar to firefighters, or if in fact they had a higher risk of working as a firefighter. So then, what's the common sense or the science behind the findings? Well, first and most important, there needs to be sufficient latency or passage of time. So most solid tumors take 10, 15, 20 years to develop after exposure first starts. Liquid tumors like leukemia, they can start much earlier, 3 years or so. All right, so latency is important. Then there's a whole series of biological plausibility aspects that depend upon exposure. That's the challenge for firefighters. Why is that a challenge for firefighters? Just the smoke from cigarettes has now been linked with all those different types of cancers, most recently colorectal and liver. So if smoke from just a cigarette can cause that many different types of cancers, imagine how much is in smoke in firefighters based on car fires, house fires, industrial fires, dumpster fires. Think about the range of exposures. So exposure is a huge challenge in these studies, and we'll come back to that. Let's first talk about what the recent research shows, starting with the Lemasters meta-analysis. So what is a meta-analysis? It takes a variety of earlier studies and combines the data. Why do you want to do that? If you have tiny studies with just a few people with a particular type of cancer, you can't tell if their risk is increased because the numbers are just too small. Our science, our statistics don't allow us to detect. But if you put those studies together, and instead of having 5 people with prostate cancer, you have 500 with prostate cancer, then you can statistically say, yes, there is an increased risk. Okay? Very powerful, very important, this approach. The disadvantages are that if the data in the studies or the studies themselves are not of high quality or consistent, then you may not be able to get results that are meaningful. Okay, so the quality of the studies is very important, and fortunately we have a number of recent studies that are very high quality. The Lemasters study, which came out a decade ago now almost, was in fact a meta-analysis, and they combined 32 earlier studies on risks for 20 different cancers in firefighters. And amazingly, they found the risk was increased for 10 of those 20 cancers. That's 50%. That's striking. Of the other 10 they looked at, risk was increased, but not statistically. Okay, so that's kind of a wake-up call. Based on that, the National Institute for Occupational Safety and Health has completed, or is close to completing, what is one of the largest, if not the largest, study of U.S. firefighters, going back decades. So this is what we call a historical cohort, meaning that the study conducted over the last 4 years looked back 60 years. Looked at firefighters in Chicago, Philadelphia, and San Francisco, and went back to their employment records to see when they were exposed, how long they worked as firefighters, et cetera. And they were able to study almost 30,000 firefighters, which is a huge number. And because it was such a large number, they were able to get some data on non-white firefighters and female firefighters. Those are much smaller numbers and harder to get good data on. They have a website, which I've listed here, that they use to disseminate information about the study over the 4 years they've been working on it. Phase 1 of the study was published in 2013, and that study compared rates of cancer, both incidence, which means cancer diagnosis, and mortality or death, in firefighters compared to the general public. And they were able to control for things that are known to impact risk of cancer, like age, sex, race, and time that the individual calendar time of diagnosis. So this is a big study. Look at that. That's almost 5,000 cancer diagnoses that can be used for incident data and more than 3,000 deaths. And importantly, they found an increased rate of just all cancer overall, both for diagnosis and for death. And they found significant increases in certain cancers, both for diagnosis and for death, specifically esophageal cancer, the feeding tube that goes into the stomach, the large intestine or colon, the oral cavity, meaning the mouth and the back of the throat, the kidney, lung, which I was actually happy to see because you breathe in a ton of lung carcinogens, and lung cancer should be at increased risk in firefighters, and a fairly uncommon cancer called mesothelioma, which is cancer of the linings around the lung or the abdominal cavity from asbestos. So that makes sense as well. They found some other risks that were present either just for diagnosis, incidence, so that's laryngeal cancer below the back of the throat, and in specific age groups, bladder and prostate, and for mortality only, rectal cancer, the liver, gallbladder, bile duct group, and in older firefighters, non-Hodgkin's lymphoma and stomach. So this is a complex, huge study, looked at lots and lots of different data, very important. They're now finishing up phase 2. Phase 2 is to try and compare firefighters across the range of exposure, okay? So this is to be able to compare the most exposed firefighters with the least exposed firefighters internally. This is much, much trickier. It's great when you can get it to work, but remember I said exposure is the huge challenge for firefighters. So they tried to look at number of fire runs over the working lifetime for each firefighter. How many times did they go to a fire? How many days were they exposed? And then the best metric, how many hours did they actually spend at each fire to get a fire run estimate? They're trying to include information on use of personal protective equipment because that's changed over the years. Whenever I talk to older firefighters, when I'm out testifying for presumptive legislation, the older guys will say, you know what? It was not cool to wear a CBA when I first joined the service. We just didn't do it. And then, you have the middle-aged firefighters who say, well, we did it, but not for overhaul because, that really limited our ability to tell if there was a risk of reignition. So, we couldn't do our job. And then our latest emphasis we'll be talking more about is what else can you do other than SCBA? So, this has really changed, and so use of protective equipment is important. Use of diesel exhaust controls is also important. The results of phase 2 have been submitted to a journal for publication, and they're being revised, so they're not available. We hope they'll be available very soon. Obviously, internal comparisons are great, but very, very challenging. So we'll look forward to the results of that study. There is a second study that I want to talk about that's very recently published, and this is the Nordic study that is done in 5 Scandinavian countries. Again, very long time frame from 1961 through 2005, but about half the number of firefighters in the NIOSH study. There are some commonalities, though. They also found an increased risk for all cancers combined. And for individual cancers, they found increased risks for melanoma and non-melanoma skin cancer, the more routine stuff that we think about. Also lung and also prostate. And in their older age groups, mesothelioma and multiple myeloma. So there's some consistency with the NIOSH study, which is good to see. Note that this Nordic study just looked at cancer diagnosis, did not look at death. There is a very hot off the press study from Australia, and I was very fortunate to run into Alex Forrest in the hall this morning who could give me a quick sound bite because this is a very large, complex study. But this looked at both cancer mortality and diagnosis or incidence in firefighters in Australia from 8 different agencies. Their number of full-time firefighters is similar to the Nordic study, but they also added in part-time firefighters and a huge number of volunteer firefighters. So that's the unique aspect of this study. They found that overall death from cancer was actually decreased. So that's a bit different from the prior 2 studies. However, diagnosis of cancer, that risk was increased for all cancers, for prostate, and for melanoma. Okay? So one of the challenges in this study is that there was a very strong effect called the healthy worker effect. Now, I'm going to tell you more about what that means in a couple minutes. But basically, if you looked at the career Australian firefighters, their risk of death compared to the general public was less, significantly less. These guys start out healthy and are staying healthy. So that makes research very tricky. It's a relatively short follow-up in this study, but moving forward, it will be a very rich source of data. This is a long report, 275 pages, so I haven't waded through all of it yet, but there's a lot more data. There's risk by age, by sex, and there's some exposure metrics in there as well. And I've listed the website for you if you want to see more. And then I want to talk about a study that came out of Korea that I originally didn't realize was relevant because it talked about professional emergency responders, which sounded kind of like EMS, but in fact 88% of their cohort worked as firefighters. So this is a big study, almost 30,000, although followed for a relatively short period of time. So we don't have a lot of cancer diagnoses yet. They did find some risks that were very similar to the NIOSH study: colorectal cancer, kidney and bladder, and non-Hodgkin's lymphoma. They tried to look at duration of exposure. Again, very tricky. Didn't find an increased risk with work as a firefighter more than 10 years, except for bladder cancer, which had such small numbers. For less than 10, it was really hard to say much about it. Many of these studies have similar limitations. Tiny numbers of individuals diagnosed with a particular cancer. The challenge is that risk for prostate cancer is not the same as risk factors for breast cancer, is not the same as risk factors for colon cancer. So you can't just lump them all together, and so it makes numbers very tricky. Limited data on exposure and other cancer risk factors and relatively short follow-up. Now let's talk a little bit about those risk factors in more detail. What effect do they have on the research? We'll talk about exposure misclassification, healthy worker, small study sizes, and data on other cancer risk factors. For exposure misclassification, a lot of the research has just basically used death certificate. Were you ever employed as a firefighter? Was that the last job you ever held, the longest job you ever held? And so if you think about all the different components in smoke, and you compare that to all the effects we see from cigarettes, it gives you a sense of how very challenging this is. And in fact, the International Agency for Research on Cancer, which Larry is going to talk about in a minute, has actually looked at firefighting, and they've said it's possibly carcinogenic. We can't say more than that, and one of the big reasons is because exposure assessment is such a challenge. all right? I think the NIOSH study is about as good as we're going to get at any point, at this point, until we maybe reach the phase where we have, you know, exposure monitoring everywhere we are through cell phones, or, you know, very advanced technology that's kind of being discussed now but is not there yet. The healthy worker effect. Firefighters enter the workforce much healthier than the rest of us, and they need to stay healthy in order to do work that is so incredibly physically demanding. However, it is that effort to stay healthy that actually reduces their risk for many diseases, including heart disease and cancer. So in the LeMaster's meta-analysis, firefighters had a 10% lower risk of dying from all causes at a given age than the general population. You saw it was a 30% lower risk in Australia. It's huge. What does that do? Well, it means that your risk actually has to be elevated above what we would consider a non-risk in order for it to show up at all. So it's really quite tricky. We've talked a bit about small studies. Firefighting is not an incredibly common occupation, and each cancer is different, so we have to look at them separately, and it makes power a real problem. Look at these sizes. The NIOSH study is in fact the largest by and large. You start dropping down when you look at the Nordic study, lower for Australian and Korea, and then it's a little less clear for the LeMaster study because the study includes lots of different study types. But it looks like the LeMasters had a lot more data on death rather than on diagnoses. Okay? What about data on other cancer risk factors? These studies, far and away, or for the vast majority, were not able to incorporate any data on common risk factors for cancer like smoking. So oftentimes the studies are criticized with the question, well, how do you know that the firefighters didn't just smoke more? How can you say that's from firefighting? We don't know about family history. It's not included in the studies. Not much on diet or other exposures. Cancer screening gets raised as an issue. Is prostate cancer really increased, or is it just because firefighters get cancer screening done? And the Nordic study specifically tried to answer that question by looking at risk for prostate cancer before and after screening was implemented in the countries involved, and found that there did not seem to be a big increase just related to screening, suggesting that screening is not the explanation for the increased risk of prostate cancer in firefighters. What do those research hurdles or challenges do to the research question we're asking? All of them, with the exception of lack of data on other cancer risk factors, result in underestimation of risk, making it harder to tell if risk is truly increased. So firefighters' risk ratios look the same compared to the general population or are not statistically significant. Now, the research is often criticized because the risks aren't high enough. We know that those factors are involved, but I want to say just a word or two about exactly how high the risks really are. How many people in this room think that if you are a spouse and you've been married to a smoker for 30 years, your risk of getting lung cancer is not increased? No one. No one's raising their hand, okay? So we all think there's enough research at this point to know that if you're exposed to environmental tobacco smoke, you have an increased risk for lung cancer. What's the risk? About a 25% increased risk. That's very similar to what we're seeing in firefighter studies. So I think the idea that the effect size is too small and we can't say it's real is just not there. So what do we do with this information? What risks do we think actually are increased? And in the absence of some new meta-analysis, if you look at the data that I've shown to you, the cancers that I have listed here have been found to be an increased risk in at least 2 of the 3 studies, LeMaster's, NIOSH, and the Nordic study. The ones that I have underlined are the ones that were significant in all ages for both incidence and mortality when it was looked at. So those are the ones that we really have the most data for. You could add bladder and kidney in if the Korea study is also used. So that's clearly more than the sort of traditional cancer thinking of one chemical and one cancer. You know, we connect benzene and leukemia, for example. But if you think about the fact that smoke and diesel exhaust and flame retardants, it's not just one exposure, it makes much more sense. Now, what are the implications from this? What proactive steps can we take? Well, first, exposure prevention is absolutely critical, and we're moving beyond just SCBA. And so my co-panelists are going to talk to you in detail about this incredibly important aspect of prevention from occupational exposure. I'm going to focus a bit on cancer screening. We've just done a major update of that for the Wellness Fitness Initiative. I'm going to talk about cancer prevention for non-occupational risks. And I'm going to finish up with just a slide or two on presumption. All right? So, wellness fitness. The screening that is recommended starts with what authoritative agencies recommend for the general population. So we're looking at what does the American Cancer Society say that you should do? What about the U.S. Preventive Services Task Force? And then for the cardiac part of wellness fitness, we looked at American Heart Association as well. But that's not good enough because you're not members of the general population. You have unique occupational risks. So what we tried to do as an expert panel is modify the general population recommendations to reflect that increased risk. And I'll show you some examples for colon cancer and for breast cancer that reflect this thinking. So first, it's important to understand that there's not an acceptable screening tool for each and every cancer. Some of them simply have physical exam components. So when you have an annual exam as part of wellness fitness, your thyroid can be palpated to see if there's any nodules that could represent thyroid cancer. The healthcare provider can look in the mouth and see if there's any sign of cancer there. Do a skin exam for both melanoma and non-melanoma skin cancer. Examine the lymph nodes for lymphoma and do a breast exam. All right? The testicular exam is recommended in the baseline initial exam for wellness fitness, and then a self-exam is recommended thereafter. Testicular cancer was a very high risk in the LeMaster study, but has not been found to be as an increased risk in subsequent studies. Still important, though, to do screening to the extent possible. Lung cancer screening. This is a huge change. For years and years, when I first started in medicine, we thought, well, you know, maybe you can do a chest x-ray and maybe that will help detect lung cancer earlier. And at one point we thought sputum cytology. You can get folks to kind of cough up as much as they can from low in their lungs, and we'll look at it and see if we see atypical or potentially precancerous cells. Those things never really worked out, unfortunately, and lung cancer has a really poor 5-year survival rate, so you'd really like to catch it early. So a study that just came out looked at low-dose CT scans and found that in risk groups aged 55 through 80 who had smoked at least 30 packs of cigarettes over their lifetime, one pack a day for 30 years, okay, a 30-pack year history, and who either currently smoke or have quit within the past 15 years, they were actually able to reduce their lung cancer death risk. Okay, so that's very important. That's something very different. Now, we need to see if that recommendation, the screening, the CT screening can be used in other groups, particularly occupational risks, asbestos, radiation, firefighting. There's lots of questions about how widely this should be used, but clearly we're recommending it in wellness fitness for smoking. Cervical cancer, this was always my success example for cancer screening when it worked, the pap smear. It's been used for decades. It's fabulous. It's still used, but there's something new that can be used in combination with it, which is testing for the human papillomavirus, which is the cause of cervical cancer. So that's a bit of a change, is adding this in as well if the individual wants it. Breast cancer has been a bit controversial. Mammography was recently recommended to start at age 50 instead of age 40 by the U.S. Preventive Services Task Force. However, reflecting the American Cancer Society and our concern about risk in firefighters, the Wellness Fitness Initiative continues to recommend it starting at age 40, but every other year up through age 50. Okay, so that reflects differing risk levels. Colorectal screening. Again, differing risk levels. There's actually a few ways that you can detect colon cancer. You can look for blood in stool. That's called fecal occult blood testing. You can actually do techniques to look inside the colon, either with sigmoidoscopy or a colonoscopy, which looks farther up in the colon, to visually see evidence of cancer. And we felt, since the majority of the studies I've presented to you show an increased risk for colorectal cancer, that we should recommend firefighters start screening, or have a discussion with their healthcare providers about whether they should start screening earlier at age 40. And if screening is chosen, we recommended using fecal occult blood testing just because it's very low risk. It'll pick up cancer, but the risk of having a colon perforation or something that can potentially happen with colonoscopy is not present. All right? Prostate cancer. More is not always more. And this has been a huge challenge. Because the reality is that prostate cancer is extraordinarily common. And so if you do autopsies on 80-year-old men who die of a whole range of causes having nothing to do with prostate cancer, you will often find little incidental tumors in their prostates that never spread, that never did anything to them. So the challenge for us is to figure out which tumors in a much younger person are going to spread and which are going to just stay there and not do anything. And we thought prostate-specific antigen could do that, PSA testing, but it's really shown that it just doesn't do a good job of it, and it leads to a lot of surgery that has significant morbidity. Okay, so you've got a real risk-benefit ratio problem there. Now, this is an extraordinarily controversial discussion, because if you talk to someone who's had their prostate cancer picked up by PSA, they will say, I'm alive today because of it. But if you talk to someone who's had a bad outcome from their prostate surgery, then, you'd really like to know whether it was necessary or not. So the change that we've put into Wellness Fitness is to have a discussion with your healthcare provider about the pros and cons and about what your individual risk level is. There are some other cancers that do not have a good screening test. Brain cancer is one of them. We really don't have a way to screen for brain cancer. Leukemia, similarly. So we would like screening tests that work, that identify early on when someone has a precancerous stage that can be treated successfully so that they can then be a cancer survivor. We don't have that yet. We would like to be able to focus our screening so that we know who is at risk and can get that screening at increased levels for those individuals. So this is still a goal. I've put a few screening resources for you here. The Wellness Fitness Initiative is in the online library under Health and Safety on the IFF's website. We are in the process of optimizing, updating this, as I said. And then I've listed the websites for you for the two organizations that are most widely followed in terms of screening recommendations. You'll notice the Cancer Society actually has what they call guidelines for the early detection of cancer. Okay. Cancer prevention. You know what? It turns out your mom really was right. An ounce of prevention really does equal a pound of cure. So you can do lots of cancer screening, and we're doing a better job now about increasing about good cancer treatment that works, increasing 5-year survival, but the best approach is proactively to prevent cancer in the first place. So the most tried and true statement in that regard is do not smoke. We've made progress. We actually have lowered smoking rates in the US, but we're not there yet. There's still way too many people who start smoking when they're young and get really addicted. The good news is that we have way more options for smoking cessation than we ever used to have before, and so that's the message I want to give you about smoking, is that for those individuals who unfortunately are smokers, not only do we have nicotine substitutes, we have a number of medications that can help to deal with the addictive aspects of it. We have behavioral therapy options, so there's now lots of options to reduce smoking. And the smoking issue applies to chewing tobacco as well, because that also increases oral cancer risk. Diet is incredibly important, and the entire U.S. is pushing against us on diet because the diets in the U.S. are getting worse and worse. Many of you may be aware about the food pyramid. So the things that are on the bottom are going to be whole grains, then fruits and vegetables. You're going to have red meats, fatty foods, fried foods way at the top, being as little of those, really limiting your consumption of those. You want to avoid calorie-dense, nutrient-poor foods. What does that mean? Most of the fast food that we eat has lots and lots of calories, but not a whole lot of vitamins, not a whole lot of fiber, not anywhere near what we could get from having a less processed diet. And then something I also don't think gets enough attention with diet is portion control. You know, if you ever go to museums that show antique furniture and antique plates, the plates back 100 years ago were these little tiny dinky things, okay? Those people weren't eating anywhere near as much. And there's a researcher at Cornell who has looked at what the size of the plates and cups do to make us think about how much we've eaten. So if you put the same portion on a great big plate, you'll eat it and say, I'm full, I'm all set, I'm feeling great. But if you put, let me back up, I'm saying it the wrong way. If you put a portion on a small plate and it looks like you filled up the whole plate, you'll eat it, you'll say, yep, I've had enough, I'm doing great. But if you put that same portion on a great big plate, it looks like, wow, I'm not getting much here at all. And you don't feel as satisfied. So there are lots of cues about diet that don't just have to do with the food. Exercise, very, very important. I know a number of fire departments have options for exercising at work as part of work. A lot of us don't have that option, and so there's something called lifestyle exercise, meaning that you fit in as much exercise as you can just in your day-to-day activities. So I take the stairs. I try to avoid the elevators whenever possible. And I was delighted in the stairwell today. The stairwells are crowded in the hotel. You all are taking the stairs too. Usually I'm there by myself, you know, coming to a door that's locked and I can't get out of the stairwell. So it's great to have lots of folks in the stairs with me. Other examples of lifestyle exercise, parking, you know, at the edge of the lot and walking to your destination. You know, just fitting in everything you can, standing instead of sitting, etc. Weight control, very important, incredibly hard to do with our diet and our limited options for exercise. Alcohol in moderation, and if you think about it, it's really everything in moderation. I think that's a key. A lot of times we feel kind of whipsawed by different research coming out saying, you know, margarine is better than butter. No, butter is actually still okay. You know, I don't think you need to do absolutely one thing or the other. I think moderation, sunscreen, etc. And then lastly, let's talk a little bit about presumptive legislation. I think it's really important. It's present now in more than 30 US states and Canadian provinces and in Australia. What does it do? The reason it's so controversial is because a lot of people don't actually understand what it does. It removes the burden for the proof of causation from the affected firefighter. If you have cancer and you're getting chemo and you can't work, and you have a family to support, and you have bills to pay, the last thing you need to do is try and find some experts who can help make the work-relatedness for your case. But that's what's required under workers' comp, okay? Presumptive legislation just shifts the burden, and it says, you know what, the employer with the deep pockets can sort out whether or not it's work-related. It does not guarantee that every firefighter who develops cancer is going to be covered by workers' comp, but it allows individual factors to be considered. Keep in mind that smoking is a very important risk factor, exposure duration, and the estimates are that the majority of cancer is not work-related. 4 to 10% gets thrown about, but those rates are higher in exposed populations such as firefighters. And the union can be of assistance in presumptive legislation. We can provide documents on science, documents on cost. Then for individual workers' compensation, the burden of proof legally is 51% rather than the 95% used in the scientific studies that I've just reviewed with you. But individual causation is complex. There are very few physicians like me who are trained to weigh individual risk factors. And so that's why presumptive legislation makes the employer scurry around and find competent people to actually think about it, as opposed to just denying it. And the IFF can be of assistance here as well with documents summarizing what firefighters are actually exposed to and the science on their risk for specific cancers from their occupational exposures. So that summarizes what I had to talk to you about today, and then we'll have questions at the end, and thank you very much.